Hi, everyone. Hello, and thank you for attending this NHRC site presentation on the topic of strategies to improve the effectiveness of cardiovascular treatment. So before introducing our speakers and panelists, I would like to remind you to keep your microphones muted and to place your questions on the Q&A box. So now it's a pleasure to introduce our speaker and panelists. Maria Carmen Bravo is a staff neonatologist and division director of the NICU at La Paz University Hospital in Madrid, Spain. She's the leader of the NPE program at La Paz Hospital and has directed NPE courses since 2010. Her specific research interests are in the field of critical care, neonatal cardiopulmonary physiology, functional echocardiography, and the assessment of brain damage with cranial ultrasonography. So our panelist, Silvia Nogara, is a consultant neonatologist at the University Hospital of Verona. Dany Weisz is a neonatal intensivist and co-director of the Pediatric Cardiology and Neonatal Hemodynamics and TnE program at Sunnybrook Health Science Center in Toronto, Canada. And Wyman is the Assistant Division Chief of Cardiology at CHOC Specialist and Medical Director of Echocardiography Lab at CHOC Children's Hospital. So it's a pleasure to be here, and I would like to hand over the microphone to Maria.
Okay, thank you. Thank you, Carolina, for the kind introduction, and thank you to the committee to inviting me to present this research that we have done during the last year that we hope to use to improve the effectiveness of cardiovascular treatment. So can you see my slide, aren't you? Yeah. Okay. So you already know that circulatory failure is very common in preterm infants, and especially in very low birth weight infants. If you see this table, you can see that 1 in 3 of the babies with a gestational age below 28 weeks will need cardiovascular support during the neonatal period. And there is also growing literature showing that during circulatory failure, there is an increased rate of morbidities related with blood flow redistribution. And with that, I mean IVH due to ischemia reperfusion or necrotizing enterocolitis, and even mortality. So, however, we are facing a problem with an unsolved solution because treatment failure is very common to first-line cardiovascular support. In fact, depending on the series that you can find in the literature, occurs in up to 50% of the cases. Although many factors, such as immaturity of the babies, the disease that are causing the circulatory failure, or even the circulatory failure itself, can increase the risk of morbidity and mortality, there are also some papers, as you know, that have highlighted that the cardiovascular treatment itself could be an independent risk factor for poor outcomes, especially if the treatment doesn't work, because there won't be any benefit, but the infants will be exposed only to the side effects. Let's try to unravel a little bit this enigma. So some members of the HIP Trial Consortium and Neocirculation Consortium, that are two research European groups that designed some project to test dopamine for low blood pressure and dobutamine for circulatory failure in preterm, agreed some years ago that these following biomarkers, blood pressure below the 3rd centile, lactate higher than 4, Weisz test lower than -9, low cardiac function with low cardiac output or superior vena cava flow in the low range, could be used as biomarkers for starting cardiovascular support in preterm babies during transition and circulation when there were circulatory failure. So we tested in 66 very low birth weight infants that were admitted at La Paz University Hospital and that received cardiovascular support, the rate of treatment failure in these babies that was 50%, as reported previously in some papers. We define treatment failure as the opposite to positive response to cardiovascular support. So treatment failure was observed or defined when blood pressure remained below the 5th centile for gestational age, or superior vena cava flow below 55 milliliters per kilo per minute, or there was no decrease in the level of lactate, or if metabolic acidosis remains, or if it was needed to add another cardiovascular drug within the first 24 hours after the first-line drug was started. In this case, in this particular study, we observed that those with treatment failure showed higher rate of mortality and trends towards more frequent morbidities related with blood flow redistribution. So the rate of survival free of brain damage or neck was higher in the baby that responded to medication. So remember that these figures are only for babies with cardiovascular support, very low birth weight infants with cardiovascular support. So there is not all the very low birth weight infants included, only those with circulatory failure. So for that problem, we propose 3 potential solutions that are complementary. So the use of TnEcho, plus the use of predictive models based on machine learning techniques, and the information coming from pharmacogenetics could be strategies that can be used to improve the effectiveness of cardiovascular treatment, and hopefully we can have better outcomes. So we will talk about this idea along the presentation. So if we look at this series of newborns that were admitted at our hospital and received cardiovascular support during the last 5 years, and we compare those who received TnEcho before starting the first-line cardiovascular support with those that didn't receive TnEcho because the technique was not available at the moment, we observed that there are no difference between the study groups regarding the perinatal variables. But those with TnEcho to guide treatment, as you can see in this graph, showed higher effectiveness, so the opposites to treatment failure as described before. And if we also analyze the subgroup of the babies with a gestational age below 28 weeks, we can observe also that the overall survival and the survival free of morbidities was also superior in the group of babies that received TnEcho, represented with the green bar in these tables or graphs. And these results are in agreement with the publication from the group of Toronto that showed that among preterm neonates requiring rescue treatment with inotropes or nitric oxide, TNE utilization to guide clinical management may be associated with an improved survival in this particular subgroup of infants. So in this case, both study groups didn't differ in terms of illness severity or immaturity. Because TnEcho is critical to determine the hemodynamic phenotype of circulatory failure. And along the last year in our hospital, the use of TnEcho has increased dramatically, as in many other units around the world. And we can observe that this use of TnEcho has been associated with a decreased use of dopamine and an increased use of the butamine or other drugs like epinephrine associated with the use of TnEcho. Because we have also observed in this series of babies that the main cause of circulatory failure was maladaptation to transitional circulation or acute pulmonary hypertension, and dobutamine is a more suitable drug for this pathophysiology than dopamine. What about the second proposed solution for the problem? Machine learning predictive models. Artificial intelligence is the ability, as you probably know, of a computer to simulate human intelligence based on a substantial amount of data, sophisticated algorithm, and a high computational power. And is going to offer a tremendous range of benefits in the area of the health system under the principle of the 5 Ps. We can predict, we can know what is going to happen later on. So for example, we can know whether someone is going to, or the likelihood to have cancer. So with this information, we can use it to prevent putting in place specific strategies for this person, personalized according to this specific disease. And everyone can have access to this information. So it will facilitate the participation of each person in their own health, and it will be possible even to give access to more patients to this health information. So we can implement even in remote areas, population interventions. And how machine learning works. So just trying to simplify a little bit, we have a database. We are going to introduce in a computer that is going to analyze all the data. The computer or the program it will go to try to find patterns, to do clusters of this information and to classify all the information in subgroups, and with that can make predictions, trying whenever another new information unseen by the program is presented, the program or the algorithm is going to try to find what is the pattern that is more similar to the new data, and with this can go do a prediction. So we can use that during the decision-making process. Predicted artificial intelligence to refer to the output of an algorithm that has been trained on a historical data. I'm going to try to do an example with this information. So now it's going to be used to make a prediction about future or unknown data that we haven't seen before. When we talk about supervised learning, we tell the model what is positive and what is negative outcome. Or in other words, we are going to say to the program or to the algorithm, this is a dog, this is a muffin. Now I'm going to show again the technology, many muffins and many dogs that the technology hasn't seen before. And it's going to try to classify, finding the pattern, and it will tell me what is a muffin and what is a dog. So the same thing can be done with treatment response and treatment failure. So I can train the machine telling them this is treatment response, this is treatment failure. And then I'm going to show you new population that you haven't seen before. And the algorithm can tell me what is treatment response and what is treatment failure. And I would like to show you what are the most frequent models that are used in medicine for trying to make prediction with machine learning. So the first one that is one of the most popular are the logistic regression. These models are easy to be interpreted, and in this case, logistic regression is going to predict the probability of the data point belonging to a specific category that can be 0 or 1 by transforming this linear combination of input features into a probability using this sigmoid function. So the probability is then used to classify all the data point in one of the two categories, and the threshold normally is 0.5. Everything above 0.5 is going to be classified in this category, and below 0.5, for example, in this other category. Other model that is very commonly used in medicine is random forest, that uses many multiple decision trees to make predictions with some trees and branches, and it operates by constructing multiple decision trees to find the final result. Another model is the k-nearest neighbors. So in this case, it's a non-parametric method that classified data points based on the majority class of their nearest neighbors, what is more similar to this new data. So when I show the machine learning model, this new data point, if it is close to this category, is going to be assigned to this category. And for linear discriminant analysis, LDA is a parametric method that seeks to find linear combination of features that separates different classes. So the problem with this model is that it's going to make assumption about data distribution like it's a normality, while k-nearest neighbors doesn't make this assumption. This is the main difference between both. So we try to apply these machine learning methods to know whether we can be better in trying to know in advance what is the effectiveness of a certain drug used in a specific baby. For this particular hypothesis, we tested 84 very low birth weight infants. Some received dopamine, some dobutamine, and some adrenaline as first-line cardiovascular support, and we needed to have a model for each drug. So we again try to identify the treatment response that happened in only 45% of the cases according to our previous definition. And for us, we thought that is something important because treatment failure is associated with mortality, irrespective of other perinatal variables according to the multiple regression analysis. And now I want to present you the models. It's a busy slide, but I would like to explain kind of how how to understand what does it mean, these colors and numbers. So in the case of epinephrine and dobutamine, the selected model was logistic regression, but for dopamine, we decided that the best model, because of the accuracy that was superior, was random forest. So here, the model presents the variables that has selected that are the more meaningful for the model. In the case of logistic regression, we have the direction of the interaction between any features and the outcome. So the red color means that the outcome is positive for these variables. Any pixel is a baby. So we have more babies with dobutamine, more with dopamine, and a few with epinephrine in this cohort of babies as first-line cardiovascular support. And the blue color means that is the negative direction with the outcome, so means that it's more common to find treatment failure. And the darker the color, the higher the weight in the model. That means that the model decided to take this feature more times for making the prediction. So you can have an idea about what is the direction of the feature in the model and also the weight of this feature in the prediction. For random forest, we don't have direction, so we don't have blue and red color. We only have weight according to the dark of the color. So darker color is higher weight in the model. So we used also this technology to test whether we could have a prediction for the efficacy of ibuprofen for treating PDA. Because although we already know that universal treatment of PDA in very preterm infants haven't shown so far any clinical benefit, but in a selected population with high likelihood of PDA-related morbidities, PDA treatment has shown to reduce the risk of mortality BPD IVH or NEC. So, but still we have a problem that treatment failure is very common, 30 to 50% of the cases depending on the publication. So the exposure to a treatment that is not effective is futile or even harmful. And this is the reason why it is so important to define the a priori treatment failure likelihood, because we aim to maximize the benefit in the responders and to avoid the potential side effects in the non-responders. So for this specific study, we used a previous database of 146 infants that we had included in a clinical trial. So we randomized babies for receiving ibuprofen in continuous infusion and bolus infusion. And again, we classified the babies according to the response to the treatment. And we observed 50% of treatment failure, and those with treatment failure, for this specific study was defined where the PDA was larger than 1 millimeter after finishing the treatment course of ibuprofen. So treatment failure was associated with lower gestational age, birth weight, and chorioamnionitis and sulfate, antenatal sulfate. And if we look at the echocardiographic variables, we observe also that treatment failure was more frequently seen in babies with lower ductal diastolic velocity, higher left pulmonary artery diastolic velocity, higher PDA score according to our definition that is just written here in the slide, and also treatment failure more frequently when the likelihood of spontaneous early closure was lower. That is something that we expected. So identifying the a priori likelihood of a spontaneous closure is important to limit unnecessary treatment exposure. So neither PDA size or LA to aorta ratio predicted treatment failure, which is not worthy, as these are the most commonly used biomarkers, echocardiographic biomarkers, to define hemodynamic significance in the majority of the clinical trials. We selected logistic regression as the best model, not only because the area under the curve, and although it's not great, it could be better to have for sure above 0.8 for having a more precise model, but it was the best for us, and also because as I mentioned before, logistic regression offers us the idea of the direction of the interaction of the features or variables in the outcome in the model. So some variables can be modifiable. So this is why it's important to know whether these variables has a particular impact on treatment failure or treatment positive response. And finally, the last solution that is complementary to the other ones is the knowledge of pharmacogenetics. So pharmacogenetics is a branch of precision medicine that aims to establish a bridge between data to personalize patient care. Precision medicine requires not only computational infrastructure, but also patient phenotypes and genotypes, because this knowledge of the drug metabolism may aim to guide cardiovascular treatment, because this pharmacogenetic information can be used for personalized the treatment of the babies when only a given drug should be administered if successful treatment rate overcomes the potential rate of side effects. And in fact, when we built a predictive model for treatment failure of ibuprofen, we observed that pharmacogenetic information, as you can see here, were selected by the model in 50 of the 46 features that were included in the model. So it was observed that when the cytochrome 2C8, that is one of the allotypes of the cytochrome that metabolize the ibuprofen, have this particular activity present. So the babies had higher rate of treatment failure compared with those with slower enzymatic activity. So in other words, a baby that have longer medication in the blood, if the medication stayed longer because the metabolism was slower, the treatment was more effective. So in this figure, it is represented the relevance of each variable in the predicted model, and the features used in the model are represented here in the ordinate axis, and the weight of the feature in the abscissa axis. And those features predicting therapeutic response are to the right side of the value 0, and those related to therapeutic failure, and at least in this model, are represented at the left side of the value 0. So the larger the bar in the graph, the greater the weight of the variable in the machine learning models. And this just gives me to give you the conclusion of this presentation. So we hope that further information will be obtained from these personalized elements of medicine with the help of TnEcho that allows to delineate the hemodynamic phenotype of each infant to better guide the first-line cardiovascular support to be used in combination with predictive models built with pharmacogenetic information that provide with a priori response to a given drug before administered in a baby and can help us during the decision-making process. And hopefully we could decrease treatment failure, and consequently we could improve the survival free of morbidity. And thank you very much for your attention.
Thank you so much, Micah. That was a really fantastic talk, and I invite the audience members to put some comments, questions in the chat for us to go through. So I'll start us off, and we can have our panelists join the discussion. I think one of the striking things that you talked about was comparing machine learning to traditional epidemiological methods. Where do we see the role for, will machine learning replace how we currently do our data analyses? Will they work together to give us more detailed analyses, or how do we see the integration of machine learning methods and traditional epi methods moving forward?
Yeah, I think that in fact in our database we include a little bit of everything, because we didn't know what have more impact in the prediction. So we trying to include epidemiologic, like perinatal data, data coming from the mother, clinical data, echocardiography, pharmacogenetic. If we could include even images, it could be great, but so far we don't have, at least in our hospital, the possibility to include everything. But I guess that we are starting kind of the first steps to something that can be very big. I think that artificial intelligence can be very helpful if we use it properly, but we already don't know how to integrate everything that is close to us in our environment to have better or more accurate models.
Thank you. So there's a question in the Q&A box. It says, thank you for your great lecture. Did you check also side effects profile according to metabolic and genetic factors?
It is difficult to know, because for us, we explore necrotizing enterocolitis, IVH, but we already don't know whether it's a side effect of the medication or whether it's really a situation that happened associated with the PDA. In terms of other side effects, like for example, renal insufficiency, oligonuria, increase of creatinine, we didn't explore specifically the pharmacogenetics for this specific outcome. But it could be great also, because I think that is another branch of the pharmacogenetics, not only for improve the efficacy of the drugs, but also to prevent people that are more vulnerable to this specific drug. For example, the typical example is gentamicin for death. That is something that is already being done. Like if you have this specific gene and you are vulnerable to have a hearing loss because of gentamicin, if you know in advance that you are going to develop that with gentamicin, it shouldn't be done.
Thank you. So I would like to ask, in the meantime, we have more questions to all our panelists. Do you use NIRS in your unit? I was thinking, like, do you think like somatic NIRS will be useful to determine the success or failure, like ahead of the cardiovascular treatment? Because sometimes we have like more data on somatic NIRS before blood pressure.
Yeah. I think that what I have learned, because I'm a doctor, I'm not I'm an engineer, so probably I have some lack of knowledge about machine learning, but my understanding, just doing the research with my colleagues, the engineers, they always explain to me that sometimes if you have not that many babies, so if your sample size is not that big, and you have many data, it's very common to have overfitting. So it's very easy for the machine to know that this is the baby that you are talking about. If it is so defined, you know what I mean? So it's very easy to try to accommodate the new one to something that is so precise. Is the perfection will be to have, of course, many variables, nears, everything, but many, also a large sample size, because if not, I think that the risk is really that your model is very precise for defining your database, but not for an unknown database. You know what I mean? And you have to balance a little bit of both. We use NIRS. We use NIRS for clinical practice and also for research. What we have learned is that in terms of efficacy and on also the side effects of medication, our perception is that probably the trends is more useful rather than the value itself. So I think that needs quite a lot of sophisticated collection methodology, and also how to analyze, because it's not just data points like every 1 minute or 5 minutes. It's really, if you have a continuous register, I think that probably can be more useful for making predictions with machine learning. But at least in our unit, we are a little bit far away from that. So still now, hopefully we can reach the point.
Wyman, I see you shaking your head. Do you want to chime in? We can rotate.
Dr. Bravo, that was a wonderful presentation. You're doing some amazing work. I wish I knew it better. But I have one question when you were presenting your methodology, which was the use of TnE. Now, in some labs that equates, or in some NICUs that equates to having a neonatal hemodynamic specialist involved. So how did, in your study, did you tease that out? Because I don't even know that our profession teases it out well, because you're getting a neonatal hemodynamics consultation sometimes when you're getting the TnE, and sometimes not. I'm not sure in your study or in your NICU, do they both come together, or do they sometimes come separately?
I mean, we have an hemodynamic consultation, but doesn't cover 24/7. So we don't have so many faculties trained to do the technique properly, to extract all the information. So in this specific study, there are babies that had TnEcho, and even like what I saw before, because it's a retrospective study, so some of these babies are the ones that I saw before, like TnEcho versus not TnEcho before starting cardiovascular support. In this particular study, we observed that those with TnEcho before starting the cardiovascular support used to have more treatment positive response. So, of course, having the full hemodynamic profile and defining what is going on with the TnEcho is going to have a great impact. I don't know whether having this perfect 24/7 and great knowledge about that, I think that probably the machine learning model still can add something, especially if we incorporate pharmacogenetics, because imagine what I have in my mind. If you face a baby, hypoxic ischemic encephalopathy, pulmonary hypertension, circulatory failure, and you do the TnEcho and you decide to start cardiovascular support, and you are trying to say, okay, dobutamine or low dose of epinephrine. In this case, if you are choosing between two, I think that TnEcho sometimes cannot give you the information to know what is best, but maybe there are something behind the baby, pharmacogenetics, diabetes, chorioamnionitis, I don't know what is inflammation, I don't know, but maybe there is something that can tell you a little bit more if you know a priori what is going to be the likelihood of response of the baby. Maybe we can improve a little bit from the baseline.
And I guess that would be my point here is, are you getting the expertise or are you getting an echocardiogram? And what is it on an echocardiogram that is guiding the therapy? I think it's important to tease it out as your field goes forward, as the neonatal hemodynamics goes forward. Some people are using TnE, not just your study, but many studies are using TnE as a surrogate for getting a consultation and getting expertise, expert advice on the patient. So I think, I'm not sure in your study how you work that out, but there is the chance that it's not the imaging or a finding on the image, but it's the expertise that you're getting that is making the difference. And I'm not sure, so that's just a question for your methodology.
Yeah, I mean, of course, for that, I guess that we probably will need to review, like with an external person, like reviewing all the echocardiographies, like to make an agreement whether the diagnosis was correct for like coming from a committee or something like that. So this wasn't done. So we only included the babies with TnEcho, yes or no, and the biomarkers collected with the TnEcho. When you have many missing, so if the echo wasn't perfectly done, the variables were not included, because if you have many missings, is not useful for the model. Yeah.
So along those lines, I have another question, maybe a bit controversial, but after all these years, we're still discussing, should we treat a PDA, which PDA should we treat, etc. And we've been coming at it with kind of the same set of expertise and perspectives. But do you think, this is a question for all the panelists actually, is there a role maybe for machine learning to look at these questions differently and maybe guide us in a different direction to answering these age-old PDA questions?
Maybe Dany or Silvia, we'll start with you.
Sure, happy to chime in on that. I think that's what's been missing so far. I think we all need to acknowledge that there's a possibility that that treating PDAs are actually not helpful. That there's certainly recent data, the systematic review of all the early treatment trials that use screen and treat and early ibuprofen treatment, that has shown harm, right? That if the average treatment effect for the average baby with PDA treated on day 2 or 3 with ibuprofen, that has the potential to cause harm. What machine learning might help us do, and likely will, is that on a more individualized basis, and this talks to the personalized medicine approach, that trials give us the average treatment effect, but that encompasses babies, again, that are likely to have potentiate harm, and others that may actually have a benefit. And there are so many variables involved, and then when we are outside of clinical trials, of course, which focus on generally, keeping one variable constant and ensuring distribution of confounders equally across treatment groups, but that there may be a subgroup of babies that may yield some benefit from it, and so that's where machine learning can identify these trends that colloquially put it, that the human eye or the human mind simply can't identify by conceiving the data or thinking about the data ahead of time. I think that's the black box or somewhat the magic of machine learning. We are across a lot of sites in Canada and within Iowa, we are running a study called the Reset PDA study, where we're gathering hundreds of data points for babies with PDA, including comprehensive echocardiography markers, as well as quite substantial clinical data. And part of the analysis approach, as we are hopefully wrapping this study up in the next year, is not going to take the typical statistician-driven analysis, but also to use machine learning in a secondary analysis to see what our human approach is going to be missing, whether the machine learning approach is going to yield a different set of predictive models to have the PDA or risk of adverse outcomes. And I'll wrap up by saying that I think Maria's approach is an important one, because it starts off with outcome-driven. It is basically outcome-driven research, and that's where we need to. We always need to bring our although we're focused on the physiology. Ultimately, when we're in the grand scheme of things, as we're seeking to export physiologically guided care and personified care for each baby, it has to be driven by clinical outcomes. I think that approach and focusing on outcomes and then working backwards to see which babies are at risk and identifying the population that may potentially benefit is the way forward. As I mentioned, I think machine learning is going to help us find the subgroup of babies that may potentially have a benefit from these treatments.
So that's very interesting, Dany. As I understand it, even like with the example you just gave with the Reset PDA, predefined variables are chosen by us humans to decide what to look at. But can machine learning tap into, like, we don't know what we don't know, to a wider range of variables to dump in into its analysis to maybe find things that we're not even looking for? Is that one of the benefits of machine learning? Maybe there are some factors related to PDA treatment or treatment efficacy that we're not even looking at yet because of the limitations of humans. Am I looking at this correctly?
Yeah, I would say that's exactly it. We have, we are for this large prospective study, we are collecting hundreds and hundreds of data points and hoping that the machine learning models can sort that out in ways that potentially human analysis cannot. So our primary analysis is going to be a partial least discriminant analysis. So we are going to be coalescing lots and lots of variables into a smaller subset based on collinearity, and we're trying to create parsimonious models to predict adverse outcomes amongst babies with PDA. But it's still somewhat of a human-driven approach. And the machine learning algorithms, they're all different, and that leads to problems with repeatability and sometimes believability with any machine learning algorithm, but has the potential to uncover relationships that we simply can't conceive or maybe didn't even think that they were appropriate. The limitation that you mentioned, Ashraf, is still very germane here, that ultimately, if you don't have data, the machine learning algorithms simply can't process it. So it's incumbent upon us to have a very, very large cohort. Machine learning is really ideal for big data, ideally hundreds, if not thousands of cases and thousands of events, but really is the environment with which machine learning algorithms can thrive. So even with the Reset PDA study, we may have 600-700 babies, of which half of them have the event of interest. It's still not the sweet spot for machine learning. And I think the future is, because neonatology is a relatively small specialty compared to, say, adult cardiology trials where there are hundreds and thousands of patients. Because neonatology is still so small, we have to leverage connections, collaborations across multiple international sites to generate that big data in order to harness the power of AI. That, of course, takes millions and millions of dollars. I'm looking forward to someone paying for all that.
Silvia, what does your site do? Do you guys have these big data sets, comprehensive echoes that you can use to generate a lot of research, or are they really quite focused echoes with limited data? Oh, you're muted.
Okay, can you hear me?
Yes.
So we don't have that big data and the opportunity to integrate with such a program. But what we try is to put a lot of data together and just try to adapt the treatment to the patient. I know human, and I hope that the program she will develop and will improve what human cannot understand. And this is a great idea and opportunity for the future for sure. But it's something we're not used to doing in our units.
Yeah. One other thought. I mean, we have a lot of time, like from a hemodynamic perspective, we're often asked to consult on acute critically ill infants. That's a very difficult population to study. And so it's very difficult to create kind of research programs around these patients, those that unexpectedly develop acute pulmonary hypertension or septic shock or whatever. They're really hard to study prospectively. So can we use machine learning in these types of more difficult populations, because we'll get alternate data sources that we might not be able to get from, you know, our regular reviews of echocardiography?
Yeah, I think that we can use in every population, and for sure the unanswered questions could be great. The main problem is again the sample size. So, and also because even in the neonatologist community, we are not happy even with the definition. So we don't know, I mean, when to start cardiovascular support, what is treatment failure, what is treatment response. So for doing like multi-center clinical trials on different conditions, we really need to have a very clear condition only with one drug, because it's one drug, one model. So imagine the escalation of the sample size that we really need. So I think that probably we really needed to sit and to just to make an agreement to define like what is circulatory failure, what is treatment response to circulatory failure. And with that, maybe it could be easy to share database, but if not, is very challenging. Yeah.
Hey, Micah, have you run into issues with expanding this program through different databases? So like different EMRs across different sites? Are you really limited to just your site because of access of data?
I mean, for example, the model that I have presented here is very modest and can be combined with other models because it's not very precise, for example, from the TnEcho point of view, because it is like an old database that included many babies. So probably the only kind of different thing is really pharmacogenetics that is kind of specifically done in this population. So, however, probably in our case, these babies didn't receive an echo many times because of a screening test or something like that. They were babies clinically sick with circulatory failure according to the biomarkers definition, and then started cardiovascular support. So maybe if we combine circulatory failure coming from other definitions, for example, you start treatment just because of the echo findings, but completely, I don't know, asymptomatic baby. I don't know whether they are the same babies. So this is kind of a little bit the difficulty. If this is not the worst thing, is to have an heterogeneous population, I guess, to try to do a model.
Yeah, Dany, go ahead.
Yeah, thank you. I think the nail on the head there that when we're looking at machine learning, it's an epidemiological driven process. Looking at statistical correlations and associations with of predictors and outcomes. Also, if say for you have a preterm baby where we think there's circulatory transition failure, she showed in her data quite eloquently that the specific underlying etiologies are actually quite diverse, from cardiogenic shock to simply vasodilatory shock. There can be sepsis, there can be a combination. And there, for me, although machine learning is fancy and it's certainly very interesting, but ultimately I still can't get away from the likelihood that physiologically driven intensive care is seen the best way to go. So and sometimes the machine learning models, depending on how much data we've put into the model, it's not quite able to distinguish the underlying pathophysiology data that's put in. And asking the machine learning algorithm to determine whether epinephrine or dopamine is better, those are two different drugs that do two different things. So sometimes the diagnostic precision of TnE is we can understand it more cleanly because we're not putting it through a black box of a machine learning algorithm, and we're kind of more directly personifying the treatment approach. So I did want to ask, and I guess I just spent a minute talking, but I want to ask Mega, how did you when you sent this data, when you provided data to the machine learning algorithm, was there enough physiological data for the algorithms to identify the underlying pathophysiology? And then was there also the breadth of babies who were treated sufficiently differently despite this having the same pathophysiology, or was there this heterogeneity of underlying pathophysiology? Was that an issue?
Yeah, for sure. I think that this is the great kind of limitation because, I mean, we assume that the babies that have had TnEcho had a more pathophysiologically guided treatment. So probably the condition was properly addressed, the drug was better selected. So this is why the treatment response was higher. But again, we are assuming, and I mean, there are babies that they didn't have TnEcho because we don't have the service 24/7. So some babies had the echo after starting the treatment, but you only take the values before because you want to build a model just to offer all the information before starting the drug because you want to use the model for the decision-making process, not like to know afterwards what is going on. So if the baby didn't have the TnEcho for the decision, was kind of selected no in the cell, like saying this baby has received TnEcho is no because you didn't use it for making the decision. And of course, some babies could have a wrong decision, even having the information. So we haven't evaluated that in the study.
Yeah, I think
Hopefully, I mean, yeah, I think that hopefully with the training programs that we are trying to implement and these kind of courses and lectures and curriculum, hopefully we can extend more these hemodynamic programs and finally, at least this kind of tick can be done in everyone. Like for sure, the decision was properly taken and we are just improving over that. So the human thing has been done. Let's go for more things that are kind of outside our scope of, Yeah.
Could I interject here? I wonder if we've done enough on the human side, but I agree with you. You've done a great job here. Small comment first, I think with any machine learning model for publication, I think it's soon going to become a requirement that you have an external validation data set, and so that would overcome, help others trust the model and just avoid, potentially overestimating the benefits of an overfitted model. So I think for publication, many journals are starting to just say, if you don't have that, please get an external validation data set and analyze that. As far as the AI PDA, Dany knows this and others know this. About 2 years ago, Patrick McNamara and I, within the confines of the American Society of Echo, formed an AI PDA group. We tried. I thought we could tackle this issue, or I thought this might be an interesting issue to tackle. Turns out it's just so complicated. The issue of PDA is just so complicated that we didn't get very far, and now we're come to the idea that maybe we just need to continue sharing what everybody's doing rather than trying to design one major study that could solve everything. The reason I say that is because I think from a cardiologist standpoint, point of view, we still, the community still needs to define which outcome they're looking for. and how they're going to score hemodynamic significance for inductance. And those two things are agreed upon. And those are human things. Those machine learning will never tell you what the outcomes you should look for are, until the neonatology community comes together and says, this is what we think is the measurable outcome, survival, etc., developmental score, BPD, if you can agree on that, length of stay. You just need an outcomes that you can all point to, that we can all point to, say, this is what we're going to measure. And now we're going to see what variables affect that outcome. We don't have a great tool for measuring perfusion. So you have this perfusion score, diagnosis of perfusion based on several variables. And even the PDA score, when you say PDA score, which PDA score do you mean? And in some instances, everybody agrees upon one score, and in large multi-center studies, we still even have to discuss that. So I think there are still a few human things that we can do, but I agree that machine learning AI will add a lot, and I think is the right thing to do. One thing that is coming, I hope, but it's coming very slowly, is the federated model that will allow us to, I think, share data without having to go through all the difficulties right now of data sharing agreements, data use agreements between individual institutions, because I think, at least in cardiology and in neonatology, one of the limiting factors is getting the data, as you all know, and I think to get large numbers, what the answer coming down the line may be this federated model where the algorithm gets transmitted, but you don't have to upload data points, you don't have to upload individual patient information into the cloud, but that's years away. The image analysis is probably at least 1 or 2 years away. So all those things would help. So I'm not throwing water on this whole project. I think it's an exciting project. You're doing great work, but I think we could do a little better if we come together. I think we would.
Yeah, and perhaps moving forward, we can think when we create our data sets for our work in the next few years, we can keep machine learning in mind so that we have that data available for machine learning to tap into when it's ready. I think this is amazing, Micah. Are there any final comments from the panelists before we close out our discussion today?
So I would like to ask something to Silvia, just because she's very interested in 3D echo. So do you think 3D echo can give us extra information to guide treatment? Maybe, I don't know if you have tried with PDA or any other clinical situation.
Yeah, so for now, I think that 3D echo is really at the beginning of its potential. So what I think is we need to understand first if it's applicable to the clinical practice, and then we can try to introduce this also in the machine learning and see what it will say to us. But the path to it is a great path, I think.
Thank you, Silvia, and thank you to all of our panelists, and definitely thank you to Micah for a fantastic discussion today. Really novel, different perspective on the work that we do in hemodynamics, and I think giving us a lot of insight and hope for the future for where this field will go. Thank you to all the attendees, and please fill out your evaluation forms. We'll see you next time.
Thank you for having me.